Hi, so in this video we will read about respiratory distress in newborn from Marrow edition 6. Let's start. Features of respiratory distress. Any two of the following must be present. The respiratory rate should be more than 60, chest retractions or indrawing present, or grunting and cyanosis. Okay, so any two present, then we can call it a respiratory distress. What? Respiratory rate is more than 60, chest retractions or indrawing, and grunting or cyanosis. Expiration is what is grunting? We are going to read about the grunting. Expiration is expiration in a partially closed glottis by the baby to prevent the collapse of alveoli. It produces a sound, right? So the baby's glottis is partially closed so that the collapse of alveoli doesn't occur. It produces a positive end expiratory pressure that prevents this alveolar collapse. Okay, what is producing a positive end expiratory pressure? This partially closed glottis. Okay. Now the causes of respiratory distress, they are divided into two: pulmonary causes and non-pulmonary causes. Let's first read about the non-pulmonary causes. First one is the cardiac failure due to certain congenital heart diseases can lead to respiratory distress. Second one is the metabolic causes like hypoglycemia and hypocalcemia. So in non-pulmonary causes of respiratory distress, there was cardiac and there is metabolic. Now coming to the pulmonary causes, which are more common. First one is the transient tachypnea of newborn, which is the most common one. Second one is the respiratory distress syndrome. Third one is the meconium aspiration syndrome. Fourth one are the air leaks or the pneumothorax. Fifth one is pneumonia. Sixth one is the anomalies, that is congenital diaphragmatic hernia. So we will read in detail about all this transient tachypnea, this respiratory distress, meconium aspiration, pneumonia, anomalies, congenital diaphragmatic hernia and air leaks. Let's start with the monitoring of respiratory distress. There are two important scoring systems for the respiratory distress. One scoring system that we read earlier was Sarnat and Sarnat staging for hypoxic ischemic encephalopathy. In this video, we will read about the respiratory distress scoring system, which includes the Silverman-Anderson scoring system and the Downey scoring system. This Silverman-Anderson scoring system, that is useful for monitoring of preterm babies with the respiratory distress. Okay, let's read about this Silverman-Anderson scoring. Which criteria are being considered under it? First one is the upper chest retractions. Second one is the lower chest retractions. Third one is the nasal flaring or the nasal dilation. Fourth one is the xiphoid retractions, and fifth one is the grunting. So let's start with the first one, that is the upper chest retractions, and we have to accordingly grade it like 0, 1 and 2. So if the upper chest retractions are synchronized, then 0. If there is chest lags. What is chest lags? That during breathing, abdomen moving outwards, during inspiration, chest only slightly moving outwards. Okay, so this is chest lags, that chest is not moving as much as the abdomen, leading to this chest lags. There is also something called seesaw respiration, that is abdomen is moving outwards during inspiration and chest is moving inward. So this seesaw respiration, we will grade it 2. That is there is respiratory distress is severe, right? In lower chest retractions, if present, if the lower chest retractions are marked, we grade it 2. If there are mild, 1, and if there is no lower chest retractions, then 0 score. For nasal flaring, if it is marked 2, if it is mild 1, if there is no nasal flaring, then 0. Xiphoid retractions, if they are marked 2, mild 1 and no, then 0. Grunting, if heard with the naked ear, then 2. If heard with the stethoscope, then 1, and if there is no grunting, then 0. So this was all about this Silverman-Anderson scoring system. How is it interpreted? Minimum score is 0, which is normal, and maximum score is 10, which is completely abnormal. So if less than 5 score, then there is mild respiratory distress. If 5 to 7, there is moderate respiratory distress, and more than 7, there is severe respiratory distress and impending respiratory failure that requires advanced forms of ventilatory support. Okay. So more than 7 is the severe respiratory distress. Fine. Moving ahead to the another score, that is Downey's Vidyasagar score. Again, this is also rated from 0, 1 and 2. Which features are considered? Respiratory rate, cyanosis, air entry, retractions and grunting. So grunting and retractions were present in both. Here in the above one, the retractions were divided into upper and lower retraction. Here it is given commonly. So respiratory rate is being considered in this one. So respiratory rate of less than 60, 0, 60 to 81 and more than 80, then stage 2, or if apnea then also grade 2. Scoring will be 2. Cyanosis, if there is no cyanosis then 0, if cyanosis in room air then 1, and if cyanosis with oxygen support at FiO2 more than 40%, then score 2 is given. Air entry if normal then 0, if air entry is decreased then 1, and if air entry is barely audible then 2. Then coming to the retractions, if there is no retractions then stage 0, if 1 then mild, and if 2 then marked. Grunting, no grunting, 0, heard with a stethoscope, 1, and naked ear 2. This grunting one was same in both, and this retraction retraction one was also same in both. The difference is respiratory rate, cyanosis and air entry. Now coming to the interpretation, there the score was more than 7 was considered severe distress. Here the score of more than 6 is considered severe distress and impending respiratory failure. We have to monitor for the oxygen saturation. SpO2 less than 90% is hypoxia. Oxygen challenge, give oxygen and observe the change in the SpO2. If more than 20% improvement, then it is a respiratory cause, and if there is no change or less than 20% improvement, then it is a cardiac cause. Okay, that's how by giving the oxygen we are finding out the cause. Okay, first let's start with transient tachypnea of newborn, a pulmonary cause of respiratory distress. So what are the risk factors for this transient tachypnea of newborn? Lower segment cesarean section in term and late preterm and diabetic mothers. So these two are the risk factors for transient tachypnea of newborn, that the newborn born via the LSCS and diabetic mothers. So what is the reason for this transient tachypnea of newborn, the respiratory distress? It occurs due to the delayed clearance of the lung fluids. That is just happening. That is delayed clearance of the lung fluids. What is the mechanism? In normal vaginal delivery, the baby is squeezed and compressed and then delivered. So the fluid that is present in the lungs is squeezed out of the lungs, and the baby can breathe freely. Because of this squeezing and compression, this fluid is squeezed out, so now the baby can breathe freely. But in LSCS there is no squeezing, causes the remnant fluid in the lungs and leads to distress. Okay. And during the delivery, there is increased expression of ENaC and sodium and potassium ATPase channels. This helps in the sodium and water reabsorption and clearing of the lung fluids. In LSCS, there's impaired expression of these channels. Okay, so what is happening? This increased expression of this sodium potassium ATPase channels, which leads to reabsorption of the fluid, also the lung fluid, and in the LSCS there is this impaired expression of these channels. So how will the baby present? Presentation, there will be breathing difficulty within 6 hours after the life, and on chest x-ray what will be seen? There will be fluid in the lungs, which will be seen as perihilar streaks or the sunburst appearance, fluid in the bronchopulmonary structures and fluid in the interlobar fissure. This is how the x-ray will be: perihilar streaks and sunburst appearance or fluid in the interlobar fissure. How will we manage? Management will be by transient condition. It is a transient condition and it lasts up to 72 hours. So only supportive treatment with the oxygen inhalation. The new guidelines for transient tachypnea of newborn, that is salbutamol inhalation and early TTBN, increases the expression of ENaC and sodium potassium ATPase channel. So we can do salbutamol inhalation. Fine. Moving ahead to the second cause, other than the transient tachypnea of newborn, there is respiratory distress syndrome. What happens in RDS? It occurs in preterm, less than 35 weeks babies, in which the surfactant becomes mature after 35. Oh, we know, right, that the surfactant becomes mature after 35 weeks, and if a baby is born before 35 weeks, then there will not be surfactant present. So what is the pathology? There is hyaline membrane disease. Hyaline membrane disease. Reason is deficit or immature surfactant levels. This causes respiratory distress syndrome. Surfactant. It is produced by the type 2 pneumocytes, and it keeps the alveoli open by decreasing the surface tension and prevent its collapse. Fine. So basically surfactant decreases the surface tension, right, and it prevents its collapse, and it is produced by type 2 pneumocytes. But in RDS, there is immature or deficit surfactant which leads to collapse alveoli, so there will be hypoxia and respiratory distress, and presentation is again less than 6 hours. Fine. So this was all about respiratory distress syndrome due to immature or deficit surfactant levels. On chest X-ray, we will see white out lungs and the ground glass appearance, also seen in the PAP, and there will be air bronchogram sign. Air enters the patent bronchi and appears black. So this will also be seen. Air bronchogram sign will be seen. So on chest X-ray, what we saw, white out lungs or ground glass appearance along with air bronchogram sign. There is another condition in which the white out lungs are seen, that is pulmonary alveolar proteinosis. It presents with white out lungs and ground glass appearance similar to the RDS. It is an autosomal recessive fatal condition. What is the reason for this? There is accumulation of old ineffective surfactant. It is also related to surfactant defect. Normally, old surfactant is removed by the alveolar macrophages, but in PAP, there is pulmonary alveolar proteinosis. Surfactant is not degraded and it keeps on accumulating. So there is no functional surfactant which is left. Fine. So it is autosomal recessive and fatal condition. Moving ahead to tests for fetal lung maturity. These can be done in amniotic fluid or the gastric juice after the birth, but are obsolete. There is a lecithin sphingomyelin ratio, that is LS ratio. Normally it is more than 2:1, that is lecithin is more, fine, and sphingomyelin is less. Phospholipids that compose the surfactant lecithin is the mature form and sphingomyelin is the immature form. More lecithin, more mature surfactant. But what is the exception here? That an infant of diabetic mother should be more than 3.5:1. Lecithin should be more than 3.5. Now second test is the phosphatidylglycerol test. It is better and more sensitive one. Third test is the lamellar body count, that is storage form of the surfactant in the type 2 pneumocytes, some detected in the amniotic fluid, and mature lung it is more than 50,000 per microliter. Okay, this was the lamellar body count, which was the storage form of surfactant. Fourth one is the shake test. 0.5 ml of the gastric aspirate plus 0.5 ml of the 95% ethyl alcohol. We have to shake it vigorously for 10 to 15 minutes and leave it for another 10 to 15 minutes. A full rim of bubbles indicate a positive test for lung maturation. Fine. So this was all about the fetal lung maturation test, lecithin sphingomyelin ratio, phosphatidylglycerol test, lamellar body count, and the shake test. Moving ahead to the management of respiratory distress syndrome that we were reading, which was due to surfactant deficiency. So, okay, in the delivery room, preterm baby less than 34 to 35 weeks with breathing difficulty, we have to suspect RDS and we have to start the CPAP, that is continuous positive airway pressure. This keeps the alveoli open and prevents its collapse. Fine. Also, if the baby is less than 28 weeks of gestation, we have to give prophylactic surfactant to prevent the RDS. Okay, in less than 28 weeks of gestation, we have to give prophylactic surfactant to prevent this RDS. This strategy is termed as the early delivery room CPAP with a selective surfactant. Early delivery room CPAP with the selective surfactant. ICU depends on the Silverman scoring. we have to do ICU stay or not, it depends on the Silverman scoring. Okay. So if the respiratory distress syndrome less than 5 score, we call it mild RDS, 5 to 7 moderate RDS, and more than 7 we call it severe RDS. This was on the basis of Silverman scoring that we read earlier. So if the score is less than 5, because Silverman scoring was for the preterm babies, right? And here this defect, respiratory distress syndrome, is occurring in preterm babies because the surfactant is immature in preterm babies only. So if the score is less than 5, we have to start the warm humidified O2, and the target SpO2 levels are between 90 to 95%, SpO2 more than 95%. So there is excess O2 and it can lead to retinopathy of prematurity. So we have to prevent this, and we have to maintain the SpO2 levels between 90 to 95% in less than 5 mild RDS cases. In moderate RDS cases, 5 to 7, we have to start the CPAP, initial pressure of 5 cm H2O, pressure and the oxygen concentration can be adjusted according to the response in the baby. Fine. And in the severe RDS, we have to start mechanical ventilation along with endotracheal surfactant therapy. Standard guideline for the surfactant therapy is the INSURE technique, in which there is intubation first, then the surfactant, and then extubation. We have to do intubation, then surfactant, and then extubation. This all is to be done if the Silverman scoring is more than 7, that is severe RDS is present, in which we have to first do the mechanical ventilation and then endotracheal surfactant therapy. Fine. Moving ahead to the newer techniques for the surfactant therapy. Okay, they are non-invasive or less invasive type. First one we are going to read about is the MIST, that is minimally invasive surfactant therapy, and second one is the LISA, that is less invasive surfactant therapy. They are done using a feeding tube or a tracheal catheter. There is something called as the early rescue surfactant therapy. In the moderate RDS, we started CPAP, right? But if there is no response on CPAP, FiO2 more than 40%, then we have to give the surfactant therapy in moderate RDS also, and this decreases the need for mechanical ventilation later on. So what is the indication for surfactant therapy? In case of severe respiratory distress syndrome and in moderate respiratory distress syndrome with no response to CPAP. Fine, this is very important to remember. Indication of surfactant therapy in severe RDS and moderate RDS with no response to CPAP. Moving ahead to antenatal prevention of RDS. How can we prevent this respiratory distress syndrome? First one, we all know, corticosteroids to mother who deliver at 24 to 34 weeks. We have to administer corticosteroids. There are two forms which is available, betamethasone and dexamethasone. Dexamethasone is common in India. Betamethasone, no, we can give 12 mg per dose, 2 doses at 24 hours apart. Okay, so total we have to give 24 mg within 48 hours. Fine. In the second one, dexamethasone, we have to give 6 mg per dose, 4 doses, then that also comes to 6 into 4, 24 mg total, and 12 hours apart. So 12 fours again is 48. So yeah, right, the total, this condition is followed, that is total 24 mg, 48 hours apart. So if we are giving dexamethasone, which is commonly used in India, we have to give 6 mg per dose, 4 doses total of dexamethasone needs to be given, and at an interval of 12 hours. So what is the benefits of this corticosteroids? It decreases the incidence of respiratory distress syndrome, it decreases the incidence of necrotizing enterocolitis, we already read in the previous video. And intraventricular hemorrhage in the preterm babies is also prevented by this corticosteroids, and it overall decreases the neonatal mortality. Fine. Now we are reading about another cause of respiratory distress, that is bronchopulmonary dysplasia, BPD, or chronic lung disease of the newborn. First we read about the transient tachypnea of newborn, secondly we read about the respiratory distress syndrome. And third one is this bronchopulmonary dysplasia and the chronic lung disease of the newborn. So again, the risk factor: preterm babies born at less than 32 weeks of gestation and babies on oxygen support for more than 4 weeks. These are the risk factors. Okay, when to assess? 36 weeks of the postmenstrual age. So again, there is mild, moderate and severe BPD. In mild BPD, that is bronchopulmonary dysplasia, no oxygen is required. In moderate one, FiO2 less than 30%, and in severe one, FiO2 more than 30%, or any form of ventilatory assistance is required. Now also let's read about this congenital diaphragmatic hernia, which is another cause of this respiratory distress in newborn. So in this congenital diaphragmatic hernia, the intestines are herniating from the abdominal cavity into the thoracic cavity via a defect. So this it is divided into two types. There is Bochdilek hernia and Morgagni hernia. Bochdilek hernia is the most common type, in which the defect in the diaphragm, the defect is present posterolateral and left side of the diaphragm. In Bochdilek hernia, we have to remember this, that is on the left side of the diaphragm. And in the Morgagni hernia, we can remember like this, right? Morgagni, and in the M we can make the A. So a very dumb trick to remember, but yeah, hope it helps. Anterior aspect and the right side of the diaphragm, because there is R in this. So there is R. Right side of the diaphragm in Morgagni hernia, and from M, anterior aspect. And in the Bochdilek hernia, the most common type, there is posterolateral. From the L we can also remember this also, right? Lateral and left side, and posteriorly. Posteriorly from can be remembered from the B, because two P's can make the B, right? Two P's like this can make, when they combine, it will make the B. This is another dumb trick. Now coming to the features of congenital diaphragmatic hernia. Compression of lungs leads to lung hypoplasia, leads to respiratory distress after the birth. So because of this intestinal contents herniating into the thoracic cavity, this leads to the compression of lungs and leading to the lung hypoplasia and ultimately to respiratory distress after birth. Heart sounds on the right side due to the right shift of the thoracic content. And there is a sunken scaphoid abdomen. Okay. As the abdominal contents are moving upwards, so abdomen will be sunken. Moving ahead to the diagnosis of this congenital diaphragmatic hernia, it can be done in the antenatal USG between 16 to 24 weeks. And after birth on chest X-ray, there will be air shadows seen in the thoracic cavity, indicating the intestinal shadows. See, these air shadows, the intestinal contents have moved into the thoracic cavity. There is no definite diaphragmatic border on the left, indicating a defect in the diaphragm. We can see the diaphragm border here, right? But there is no definitive diaphragm border in this side. Also, we can see the heart shadow on the right side, and there is absent air shadow in the abdomen. These things, air shadows, are seen usually in the abdomen here, but as they have moved upwards, there will be absent air shadows in the abdomen. So these all findings will be seen in the chest X-ray. Moving, how will we manage? Now, moving to the management of this congenital diaphragmatic hernia. It is again divided into medical management and surgical management. In the medical management, first 48 hours after the birth, we have to do this medical management within first 48 hours, that is. And what is the aim? Aim is to promote the lung expansion, to stabilize the pulmonary hypertension due to the lung compression. Fine. Two aim we have: to promote the lung expansion and to stabilize this pulmonary hypertension. So we do in treatment, we do the ventilation, conventional ventilation, then move to high flow oscillatory ventilation, and if that doesn't work, then move to ECMO, that is extracorporeal membrane oxygenation. Fine. And in the surgical management, which is done after 48 hours of life by the native tissue repair and the patch repair, that is polytetrafluoroethylene Gore-Tex repair. Fine. And the approach is by the subcostal approach, as it helps in better visualization. Now the poor prognostic factors for the congenital diaphragmatic hernia. Antenatal factors and postnatal factors. We saw, right, that we can diagnose antenatally also, this between 16 to 24 weeks, congenital diaphragmatic hernia. So if the lung and head ratio is less than 1, then it is a poor prognostic factor, and if the liver is in the thoracic cavity, then it is a poor prognostic factor. These findings will be seen on USG. And on MRI, if the derived total lung volume TLV is less than 20 ml, then it is a poor prognostic factor. The postnatal factors which are poor prognostic factor for congenital diaphragmatic hernia are: first one is the degree of pulmonary hypertension. Most important prognostic factor is this degree of pulmonary hypertension. We saw, right, due to the compression, the pulmonary pressure was increasing, leading to pulmonary hypertension, and this is the most important prognostic factor. Second one is the size of defect. Third one is the early onset of respiratory distress within less than 34 hours. That is also poor prognosis. And if it is requiring ECMO, this extracorporeal membrane oxygenation, then this is also a poor prognostic factor. Right, we read about this congenital diaphragmatic hernia, which was the fourth condition of respiratory distress. Next one we are going to read about is the meconium aspiration syndrome, another cause of respiratory distress in newborn. It is meconium aspiration syndrome that is common in post-term babies or the term babies with IUGR. Okay, post-term babies or term babies with the IUGR. What is happening is there is intrauterine stress which increases the motilin. This increases the peristalsis of the GIT, leading to expulsion of the meconium in utero into the amniotic cavity, and which is swallowed and aspirated, leading to the meconium aspiration syndrome. Stress is causing meconium to be expelled into the uterus only, into the amniotic cavity, which is swallowed and aspirated, and this syndrome happens. So the consequence of this meconium aspiration syndrome, let's see. There is partial block of main airway. This leads to obstructive emphysema, and there is air trapping during exhalation, which leads to hyperinflation in the chest X-ray. Okay. So because of this meconium aspiration syndrome, there can be two things which can happen. There can be a partial block and there can be a complete block. So if there is a partial block, this is leading to hyperinflation in the chest X-ray because of the air trapping, which is happening because of the obstructive emphysema. And in case of complete block, if the small airway is getting completely blocked, then it can lead to segmental atelectasis. Okay. Right, that segment, if there is complete blockage, so that segment will collapse. And third one is the meconium. If it is present in the alveoli, this will lead to chemical pneumonitis. Fine. Moving ahead to the diagnostic criteria for meconium aspiration syndrome. It is a diagnosis of exclusion. Meconium stain liquor if present at the birth and along with respiratory distress, then we call it meconium aspiration syndrome. And on X-ray there will be coarse ill-defined infiltrates, and we have to exclude any known condition. Then we can diagnose this meconium aspiration syndrome. The complications of meconium aspiration syndrome include air leaks like the pneumothorax and persistent pulmonary hypertension of the newborn, that is PPHN of the newborn. How will we manage this meconium aspiration syndrome? We can manage this by the symptomatic management according to the ventilatory requirements like the oxygen therapy or the CPAP, and this persistent pulmonary hypertension of newborn is managed by the inhaled nitric oxide. Fine. Let's go through, this is all done about the respiratory distress syndrome. Let's go through this all in a very fast manner, as fast as possible. So respiratory distress, there are any two features should be present to call it a child is under respiratory distress. First is the respiratory rate of more than 60, second one is the chest retractions and indrawing, and the third one is the grunting or cyanosis. There were two types of causes of respiratory distress. First one was the pulmonary and the non-pulmonary. In pulmonary, we read in detail about all these: transient tachypnea of newborn, respiratory distress syndrome. Transient tachypnea of newborn was happening because of this delayed clearance of the lung fluid, which was happening in LSCS babies and in diabetic mothers, because there is not proper compression happening, right, which happens normally during the vaginal delivery. In respiratory distress syndrome, it was occurring in preterm babies due to immature surfactant. Meconium aspiration syndrome we just read, it occurs in postterm babies. Due to stress, this meconium is expelled in utero, which is then aspirated by the child, leading to this meconium aspiration syndrome. Also, the other causes of respiratory distress can be pneumonia and air leaks and anomalies like congenital diaphragmatic hernia, which we just read. Okay, and non-pulmonary causes, it can be cardiac failure and the metabolic hypoglycemia and hypocalcemia. Monitoring, for that we read about two scores: Silverman-Anderson score and the Downey score. Silverman-Anderson scoring is for the preterm babies with respiratory distress. It takes into account the upper chest retractions, lower chest retractions, nasal flaring, xiphoid retractions and grunting. So we call severe respiratory distress if the score is more than 7. Mild if the score is less than 5. Moderate if it is between 5 to 7. Downey's Vidyasagar score, it takes into account respiratory rate, cyanosis, air entry, retractions and grunting. And in this Downey's Vidyasagar score, more than 6 score is considered as severe distress and impending respiratory failure. First, then we started talking about the transient tachypnea of newborn. We read, right, LSCS children and diabetic mother, there is delayed clearance of the lung fluid. And on X-ray, there will be perihilar streaks and sunburst appearance will be seen along with the fluid in the interlobar fissure. Management, because it is a transient condition, it will last up to 72 hours and only supportive treatment via the oxygen inhalation is done, and under the new guidelines, we can give salbutamol inhalation. In respiratory distress syndrome, which was occurring in preterm babies less than 35 weeks, pathology, there is hyaline membrane disease and defect, it was occurring due to the deficit or immature surfactant levels. Surfactant are produced by the type 2 pneumocytes and they prevent the collapse of the alveoli. And this, the baby with the respiratory distress syndrome will present within 6 hours. And on X-ray, there will be whiteout lungs and ground glass appearance seen along with the air bronchogram sign. This whiteout lungs is also seen in the pulmonary alveolar proteinosis, in which there is accumulation of the old ineffective surfactant. We read about the test for lung maturity, lecithin sphingomyelin ratio, phosphoridyl glycerol test, lamellar body count, which are the storage form of surfactant, and the shake test, in which the full rim of bubbles indicate a positive test for lung maturation. After mixing what? And shaking vigorously 0.5 ml of gastric aspirate along with 0.5 ml of 95% ethyl alcohol. Now, in the management of respiratory distress, in preterm babies less than 34 to 35 weeks, we have to suspect first this RDS and start with the CPAP. And if the baby is less than 28 weeks, we have to prophylactically give surfactant to prevent this RDS. Fine. And the different grading of RDS on the basis of Silverman scoring, we have to manage differently. If less than 5 score, mild RDS, we have to start with the warm humidified oxygen. Target SpO2 levels are between 90 to 95%. For moderate RDS, we have to start with the CPAP, and the initial pressure of the CPAP should be 5 cm of H2O, and then we can adjust accordingly. Then in more than 7 scores, severe RDS, we have to do mechanical ventilation along with the endotracheal surfactant therapy, and for surfactant, we have to follow this ensure technique, in which first we have to intubate, then give surfactant, and then we have to extubate. Moving to the newer techniques, it was missed minimally invasive surfactant therapy and LISA, that is less invasive surfactant therapy. Now coming to the indications of surfactant therapy, we just saw in severe distress, and we can also give in moderate distress if there is no response to the CPAP. Antenatal prevention of the RDS is done by this corticosteroids. In India, mostly dexamethasone is given in the 6 mg per dose, 4 doses, 12 hours apart. Corticosteroids also prevent from the RDS, necrotizing enterocolitis, intraventricular hemorrhage, and overall neonatal mortality. Bronchopulmonary dysplasia. It occurs in babies born at less than 32 weeks of gestation, babies on oxygen support for more than 4 weeks. Mild BPD, no oxygen required. Moderate BPD, FiO2 less than 30%. Severe BPD, FiO2 more than 30%. In congenital diaphragmatic hernia, it is of two types. Boscia-like one is the most common type, in which the posterolateral defect and left side of the defect of the diaphragm is seen. Features, it includes there will be lung hypoplasia leading to respiratory distress. Hard sounds will be heard on the right side due to the right shift of the thoracic content, and the sunken abdomen will be seen because the abdominal contents are moved into the thoracic cavity. Diagnosis is can be done by the antenatal USG between 16 to 24 weeks and after the birth by the chest X-ray. Right. Management. Within the first 48 hours, our aim is to promote the lung expansion, stabilize the pulmonary hypertension. So we can do ventilation, conventional ventilation. If not, then we can move ahead to the high frequency oscillatory ventilation, and then we can upgrade it to ECMO, extracorporeal membrane oxygenation. And surgical management is done after 48 hours of life by the native tissue repair or the patch repair, Gore-Tex repair, and approach is by the subcostal. Now then we read about this prognostic factors of the congenital diaphragmatic hernia. Poor factors are the lung head ratio less than 1, liver in the thoracic cavity, and derived total lung volume of less than 20 ml. Postnatal factors include the degree of pulmonary hypertension, size of the defect, and the early onset respiratory distress less than 24 hours, and if the baby is requiring ECMO. Last one, the meconium aspiration syndrome. It occurs in the post-term babies or the term babies with IUGR. Intrauterine stress leads to motilin increase, and increase in peristalsis leads to expulsion of the meconium in utero, which is swallowed and aspirated by the baby, leading to this meconium aspiration syndrome. Its consequence there can be partial block, complete block, or meconium can go into the alveoli. If there is partial block, it leads to obstructive emphysema, which leads to hyperinflation in the chest X-ray. If there is complete block of the small airway, there will be segmental atelectasis, and if the meconium is in the alveoli, there will be chemical pneumonitis. There is a diagnostic criteria for MAS, that is diagnosis of exclusion. Meconium stained liquor seen along with respiratory distress, and on X-ray there is coarse, ill-defined infiltrates. Complication of the meconium aspiration syndrome, it can lead to air leaks and persistent pulmonary hypertension of the newborn. Management, it is done by symptomatic management, that is by ventilatory support like oxygen therapy or CPAP, and this persistent pulmonary hypertension of newborn, for that we have to give inhaled nitric oxide. This was all. Thank you.